Life is full of accidents. One's fortune can change in the blink of an eye. Both penetrating and blunt ocular injuries can result in the development of cataracts. In the general population, there is 14% lifetime prevalence of ocular trauma, and 27 to 65% of these traumas can lead to cataracts. Young doctors may encounter traumatic cases in ER duty. When approaching traumatic cataracts, history taking, including age, mechanism of injury, and timeline of cataract formation are very crucial. The examination should be thorough, from anterior to posterior, and there is no consensus for surgical time. We should be prepared for iris synechia and weak zonules. Primary IOL calculation and implantation may not be possible in some cases. Like the famous quote from the movie Forrest Gump, "Traumatic cataracts are like a box of chocolates. You never know what you're gonna get." Surgical techniques. First, trypan blue or ICG can check the integrity of the capsule and facilitate CCC. The first case is a 36-year-old male with petaloid cataract. He was injured by a brick. Here we injected trypan blue, and after washing out and exchanging with OVD, the CCC could be performed effortlessly. Use of pivoting is required for a good capsulorhexis. The second case is a 37-year-old male injured by a wood fragment. We can see a ruptured cornea and anterior capsule with a flat chamber. ICG staining was done before removing the foreign body. This maneuver can prevent lens material leaking from the anterior capsule and causing poor ICG staining. Now we can attempt CCC after cornea suture. Second, iris synechia and capsular fibrosis should be managed. The third case is a 57-year-old male with focal iris synechia. Firstly, we tried viscodissection, but the adhesion was not released. Secondly, we used Sinskey hook and Y hook to separate the adhesion. We could then make a capsulorhexis bigger than the pupil size by carefully going under the iris. The fourth case had diffused iris synechia and capsular fibrosis. We used forceps and even scissors to separate the adhesion. After releasing the fibrosis, an iris hook was inserted to facilitate CCC. Third, hydrodissection should be gentle. Excessive fluid accumulation may cause posterior capsule rupture. Minimal fluid hydrodissection should be used. A 27-gauge cannula was inserted under the anterior capsule by slightly lifting the capsulorhexis edge upward. The balanced salt solution was quickly injected to generate hydrostatic force to pass across the posterior aspect of the lens. Gentle depression of the lens was performed to separate the nucleus from the anterior capsule and force out excess fluid. Cataract extraction and IOL implantation should be done cautiously. Most traumatic cataracts are very soft. After tilting the lens with hydrodissection, we can remove the cataract using only the vacuum. Hurricane aspiration technique can be used in cortex removal. We may encounter zonular dehiscence if too many axial forces were used in cortical cleanup. The capsular tension ring should be inserted carefully and cause minimal stress to the zonule. However, vitrectomy or PPLV should be performed in some cases. The fifth case has dense ASC and leaking lens material. When removing the cataract with Simcoe cannula, PC defect was noted. Poor followability and vitreous were found at the wound. Anterior vitrectomy was done, and a 3-piece intraocular lens was implanted in the sulcus. The sixth case has Marfan syndrome with traumatic lens dislocation. 3-port vitrectomy was prepared, and after injection of viscoat, the lens was dropped. Vitrectomy and lensectomy were done accordingly. One-piece IOL can be implanted if the capsular bag is intact. However, a 3-piece IOL should be implanted in the sulcus if PCR is noted. And a scleral fixated IOL should be used if there is no capsular support. For the prognosis, in this study, anterior injury was better than posterior, closed globe was better than open globe, and early hospital admission was better than late admission. There was no difference between simultaneous and second surgeries. As young ophthalmologists, we may encounter traumatic cataracts in ER duty. There is a wonderful opportunity, but also profound responsibility. As Winston Churchill once said, "Success is not final. Failure is not fatal. It is the courage to continue that counts." We should never give in, except to convictions of honor and good sense. Thank you for your attention.